Hey folks, Scott Weingart here, and this is the EMCrit podcast. Today on the podcast, chest tubes, aka tube thoracostomies. It's a dying procedure. You may need it every once in a while, but certainly not when I was training, when we used to do them all the time. They've been replaced by better things like pigtail catheters, but you still need to know how to do them, you still need to know how to manage them, and you still need to know all of the periprocedural stuff. And that's what we're going to talk about today. This is just too big to do in one episode. So today we're going to talk about the periprocedural stuff for chest tubes, the pre, the post, management of thoracic drains, etc. And next episode, we will discuss all of the actual procedural stuff for crash and non-crash chest tubes. But before we get into that, a few quick ads. Ad number one is for the Resus Leadership Academy. It is essentially a resuscitation fellowship that you could do from your own home. It's 1 year long. You will come out to be the most well-educated, aggressive resuscitation doc in your center. And you don't need to waste a year of attending level earnings to actually make it happen. If you're interested in this, we finally have space again. They go incredibly quickly. The slots disappear almost instantly. So if you're interested, go to resusleadershipacademy.com and just take a look and click the more info link and you'll get some more information there. And the second ad, of course, is for EMCrit membership. If you're listening to this, it means you're not currently an EMCrit member. And you should be, because you, I think, don't have time to read 60 journals on emergency medicine, critical care, and resuscitation. And yet your patients deserve to have the most up-to-date information in addition to the core basics of resuscitation and acute critical care. And that's what you get when you're an EMCrit member, is the full access to all of the past episodes, the full-length versions of the current episodes, and a host more options to make you the best resuscitation doc out there. So consider joining at emcrit.org/join. All right, let's get to the show. All right, so I guess we'll start off with, when do we actually need a formal chest tube, aka not a pigtail? And the hint to the answer is almost never. Let's run through it by category. So pneumothoraces, first of all, it's really questionable at this stage of the game for almost every pneumothorax whether you even need thoracic drainage of any sort at all. The conservative management in which you just watch the patient, bring him back for a repeat chest x-ray, has certainly now been well established. There was just a New England Journal article in 2020, it's in the show notes, by Brown et al., demonstrating you could just watch even big spontaneous pneumothoraces. I have another trial of watching small traumatic pneumothoraces. I mean, a big traumatic pneumothoracy, generally we're going to put drainage in, but it doesn't need to be a chest tube. In fact, there's no reason to think you need to put a chest tube in any pneumothorax. Air is small. It'll fit through a pigtail, and it's kind of gruesome to put a full-size chest tube, even the small ones, in for pneumothorax, when you could do something that's procedurally much more comfortable for the patient and leaves less of a scar, and in many cases has a lower complication rate. And I think, and I'm not absolutely sure about this one, but this is what I could glean from the literature, probably has a lower infection rate as well. So pneumothorax should never get a chest tube unless it's a crash placement or an empiric placement during a trauma resuscitation. Other than that, even in trauma, if you're going to put anything in, it should be a pigtail. Now, like I said, you could even watch these, but the middle ground that most of my brothers and sisters in the UK are doing is actually just draining with a catheter or even a pigtail itself, a big pneumothorax, and then sending them home for conservative management. And that's even safer, in my estimation, than just watching them. And it probably leads to a quicker resolution. So all of this is to say, pneumothorax, no chest tube. Okay, now, one of the last bastions of formal chest tube placement was the traumatic hemothorax, right? You could not get away with a tiny pigtail catheter in that. Well, now we have the PCAT trial, just published in the Journal of Trauma, demonstrating that even in traumatic hemothorax, like the last mainstay for the purpose of using chest tubes, that the 14 French pigtail was fine. Worked fine, no difference between the two groups. And so I think here, if it's a non-crash hemothorax, you should probably start with a pigtail and not a formal chest tube. All right, and there's another trial I'll put in there in injury. So you have two of them there saying you could use small bore catheters for hemothorax. And, Kenji Inaba has been saying this for years, and now we have the proof. Okay, what about the one where I'm a little bit on the fence on? That is empyema. And this is one where we have seen failures of smaller bore catheters, and it's bad. It's bad if you don't get these drained. They go on to need surgery when they might have avoided it, or they could actually have a far worsening disease state, and they could actually die from it. Empyemas are a big deal. And traditionally, I was taught you have to put chest tubes in these. The pigtails are not big enough. Now, the evidence goes back and forth on this one. And some of the evidence would say, and I'll put it all in the show notes, if you flush them every 6 hours, they don't clog up, and you actually can use a 14 French. Now, my take is there's a happy medium here, and I'm going to mention it a little later in the episode as well, but even in a place or a situation, I should say, where you want a chest tube, you don't need to do the brutal, barbaric chest tube procedure that we all learned. Where you basically have someone holding the patient down or full-on procedural sedation while you take a Kelly and just rip open their muscle. We now have percutaneous chest tubes, like real chest tube size. I mean, you can go up quite high. There's no reason to. I don't think there's anything out there now. I will make this statement. Someone prove me wrong. There is no disease state that requires, short of a patient in general anesthesia in the operating room where you might want to put in big drains because it's not going to hurt them, and you could do it carefully, and you could see both sides of the structure you're actually putting in it. But when you're actually doing a placement from outside the chest, there is no reason to ever go bigger than 20 French. Prove me wrong. Prove me wrong. I bet you can't do it. So 20 French, we now have percutaneous 20 French kits. The ones I use are called Thalquick. I don't know if other manufacturers make them, but the Thalquick chest tubes are percutaneous. You get a 20 in there, and I think that's perfectly adequate for an empyema. Now, as to whether a 14 is adequate, the British say yes. The American Thoracic Society says there's not enough evidence. I have one case group, cohort study saying it's okay. I don't know. This might be one where if you have an empyema, you might just want to bite the bullet and put in a percutaneous chest tube. Now, what you can do is if you put in a pigtail, now, if you're hearing this, it's because you have reached the end of the free portion of this episode. If you want to hear all of the goodness about chest tubes, then go on over to EMCrit.org/join. EMCrit.org/join. Talk to you soon.